Hello, my name is David Murray. I'm the Associate Director for Prevention and the Director of the Office of Disease Prevention at the National Institutes of Health. I'm pleased to welcome you to the final 2025 ODP Early Stage Investigator Lecture. We created this lecture to highlight early career prevention scientists who have not yet served as a principal investigator for a substantial NIH-supported research project, but who have made outstanding research contributions to their respective fields and are poised to become future leaders in prevention research. Before we begin, I have some housekeeping items. You can submit questions during the webinar via the Q&A pod. You'll need to open the pod by hovering your cursor at the top of the Teams window and then clicking on the Q&A icon. We will open the floor to questions at the end of the lecture. The slides and video recording will be posted on our website in the coming weeks. We're excited to present our final 2025 awardee today, Dr. Michael Fang. Dr. Fang is an assistant professor in the Department of Epidemiology at Johns Hopkins Bloomberg School of Public Health and a core faculty member in the Welch Center for Prevention, Epidemiology, and Clinical Research. His research broadly aims to inform the screening, diagnosis, and management of type 1 and type 2 diabetes. In this talk, Dr. Fang will draw on emerging evidence from national health surveys and large electronic record databases to describe the modern epidemiology of type 1 diabetes in the United States. He will also highlight areas of progress and emerging challenges in type 1 diabetes management, with a focus on glycemic control, obesity, and access to new diabetes technologies. Please join me in welcoming Dr. Fang.
All right, thank you, Dr. Murray, and thank you everybody for joining. I'm really excited to be able to share some of the ongoing work that our group is engaged in. And again, my name is Mike, and I'm currently a professor at Johns Hopkins University. So just to begin, I have no disclosures, but I should note that this work was supported by Career Development Award through NIDDK, so none of this work would have been possible without their generosity. So in today's talk, we're going to touch on four major topics. The first is just a little bit of background on what type 1 diabetes is, how many individuals have this condition in the US, and why I think we should care about this this condition from a population perspective. Second, we'll touch on, we'll discuss glycemic control and the use of new technologies and evaluate how these glycemic control and the use of these technologies have changed over time. We'll then shift gears and talk about obesity and weight management, which I think is an important emerging health challenge in this population. And then we'll conclude with a brief discussion on future directions for I think, exciting areas for research in the type 1 diabetes space. And so the overarching question that I'm hoping to address in today's talk is, how well are we managing type 1 diabetes in the US? So let's begin with a little bit of background, right? So what is type 1 diabetes? Typically, type 1 diabetes is an autoimmune condition, right? And what I mean by that is that it's a condition where a person's body inadvertently attacks its own beta cells. And these are cells that are in the pancreas, and they're responsible for producing insulin. And so you can see from this little diagram on the right, the role of insulin in managing and regulating glucose, right? So insulin is this hormone. It attaches itself to the surface of cells. And what that does is it opens a glucose channel. So when you're consuming foods, the carbohydrates are converted into glucose, and those circulate in your blood. And once the insulin is attached to the cells, those circulating glucose can enter the cells and then be used for energy or for storage, right? But when you don't produce your own insulin, you're going to need it from somewhere else. Otherwise, your sugars are just going to stay elevated. And that somewhere else for these patients comes in the form of therapy, of medication, right? So patients with type 1 require lifelong treatment with insulin. So the way that type 1 is typically diagnosed is you have a test for elevated blood sugars, and then they'll also evaluate you typically for autoantibodies, and those are markers that attack on your own body has occurred, right? And so if you have both of these things, typically that's diagnostic of type 1 diabetes. Interestingly, we've traditionally thought of type 1 as a juvenile disease, and the name of type 1 diabetes was previously juvenile onset type 1 diabetes. But what we're learning now is that it's a condition that can occur at all ages, right? From sort of early age to actually middle age and older adults. but it does peak at childhood, right? So it's a condition where it's most common in children, but it can occur at all ages. So how many people in the US have type 1 diabetes? I think this is such an interesting question. And it turns out we didn't actually have good data on this until just a few years ago. So the CDC collected for the first time nationally representative data on individuals with type 1 diabetes in 2016. And so our group recently analyzed these data and published these results. And so what we found was that for every 1,000 young people in the US, right, that is individuals under the age of 18, approximately 4 per 1,000 have type 1 diabetes. And then when we look at adults, for every 1,000 adults in the US, approximately 5 of those have type 1, right? So if you take those prevalence estimates and you apply them to the US Census, you can get a rough estimate of how many people in total are living with the condition. And so when we did that, what we found was that approximately 1.6 million individuals, both children and adults, are currently living with type 1 in the US. I think one really interesting thing is that if you break that 1.6 million out by age, what you'll find is that about half of them are actually over the age of 45. And I think this is surprising because, as I mentioned, this is a condition that we've typically called, or previously called, juvenile onset diabetes, right? I think in the minds of a lot of people, this is still a childhood disease. But I think the reality of it is that those children who have developed disease are now living longer than ever, and now they're reaching middle-aged and older age as well. And people are also getting diagnosed with the condition at different points in their lives as well. So now we have half of the population over the age of 45. And so I think this is an important finding and something that we have to continue to consider moving forward, right, is how to manage this condition in the context of an aging population, right? It turns out the population with type 1 is actually aging. And it's something that I don't know that we've done extensive enough research on. And so why should we care about type 1? I think one of the major reasons we should be concerned about this condition is because just like type 2, individuals with type 1 are at very, very high risk for just a litany of very serious complications. So eye disease is one example of this. So it turns out individuals with type 1 are at very, very high risk for eye disease, including blindness. They're also at very, very high risk for cardiovascular disease, including stroke and heart attacks. They're at very high risk for kidney disease, so mild kidney disease, and also end-stage kidney disease where you require dialysis. And then they're also at high risk for lower extremity issues, including nerve damage, and the most severe case of sort of lower extremity issues, amputations, right? They also have lower life expectancy, right? So we've made a lot of progress, and individuals with type 1 are living longer than ever, but there's some studies that suggest that they still live on average between 10 to 13 years less than individuals without diabetes, right? So high risk for major complications, high risk for lower life expectancy. Fortunately, what we've learned from some research, and I'll talk about that in a second, is that if you're able to manage different risk factors, you're able to mitigate a lot of these adverse outcomes, right? You're able to reduce your risk for a lot of these major outcomes that I just talked about. And so two that are discussed in the literature are glycemic control and then obesity management, right? And so that will be the focus of the remaining slides that I have ahead of us. And again, the main question is that I want to talk about in this talk is how well are we managing these major risk factors for folks with type 1 in the US? So let me shift gears a little bit now and talk about glycemic control in the US. So we know from lots and lots of studies, in particular, large randomized trials, that individuals with type 1, when they're able to achieve glycemic control, that their risk for major complications is dramatically reduced. And the most compelling data for that come from a landmark trial called the Diabetes Control and Complications Trial, or the DCCT. And what this study was it was about 1,400 individuals with type 1 diabetes. Half of them were randomized to a conventional approach, right? And so what that meant was, on average, these participants had an A1C of around 9%. And at that time, this was considered an acceptable level for these participants. And then the other half were treated down to a very intensive level, right? They tried to drop their sugars as close to normal as possible. And so the average A1C for this group was around 7%. So you had this large separation in A1C, and they maintained that difference over the course of the study. What they found at the end of the trial is that individuals who were in the intensive control group had between 50 and 70% lower rates of microvascular complications, right? Less eye disease, less kidney disease, less nerve issues in the lower extremities. After the trial was over, they continued following these individuals in post-trial follow-up. And again, what they found was that for the individuals that received intensive treatment, they had 30 to 60% lower risk of cardiovascular disease and a much lower risk of premature mortality. Okay. So the sort of simple takeaway from DCCT is that when you achieve glycemic control, you live a longer and healthier life if you are in an individual with type 1 diabetes. That was sort of the bottom line of DCCT. And so now, if you look at virtually any set of clinical guidelines, it will say glycemic control is central, right? And it will often give you a A1C target of less than 7 for a patient with type 1 diabetes, right? And that target of 7 comes directly from the DCCT, right? When you achieve an A1C of 7, your risk for major complications is significantly reduced. And for the ADA's standard of care, they gave this recommendation an A-level recommendation, right? This is based on the strongest level of evidence, strongest body of evidence that they can find, right? This is backed by rigorous RCT data. I think the other really interesting thing is that glycemic control is not just an individual level metric, right? It's not something that patients and clinicians just care about. It turns out that it's a really powerful population health metric. So when we develop population health strategies or efforts where we want to evaluate how well we're doing as a nation or globally in terms of our diabetes management, we often use glycemic control as an important indicator, right? And so in this example, this was the Healthy People's Initiative, which was a US-based effort. And we wanted to evaluate how well we were doing as a country in terms of our diabetes control and diabetes management. And the way we defined that was the proportion of individuals that were achieving an A1C less than 7 and the desired target or the desired goal was to improve that number, right? Because if we're able to improve that number, increase the proportion, then the underlying population's risk for major complications then gets reduced, right? So whether we're talking about individuals or we're talking about population health, glycemic control is just so important for folks with diabetes. The other really fascinating thing that's been going on over the past decade is just the rapid evolution of how type 1 diabetes is actually managed, right? So on the left-hand side of this figure, you'll see what is called standard therapies, right? And this consisted of vials and syringes, right? And so this is traditionally how this insulin medication was administered. You would pull it from the vial and you would self-administer it. And then if you wanted to read your blood sugar, you would poke your finger, a little bit of blood would come out, you would feed that into the test strip, and you would get a single reading of what your blood sugar currently is. And so this standard approach has been completely revolutionized not completely replaced. I'll show you in a second how it's changing, but it's been completely revolutionized by a new set of tools. And those tools largely revolve around technology. Right, so now the most common way that people are managing their sugars and evaluating their sugars is through a tool called a continuous glucose monitor. And so these devices now are small, they're accurate, and the newest generation can give you readings as frequently as once a minute, right? So rather than having a few readings per day, you're getting thousands and thousands and thousands of data points on a real-time basis. The other really fascinating thing that's happened over just the last few years is the development of what's sometimes called an automated insulin delivery system, right? So we've had insulin pumps for a long time now, and these are devices that there's tubing and then insulin is directly fed into a patient's body. But now these devices can actually communicate with each other via Bluetooth. So now your CGM will tell you, oh, your sugars are running high right now. That information will be fed into your pump. Your pump will have an algorithm that says, oh, your sugars are high. I'm going to start outputting more insulin into you. So now insulin rates increase. That brings your sugars back down. Your CGM reads that information and it says, oh, you're coming back down. You're sort of stabilizing. Let me tell your insulin pump that. then it tells it that, and then the algorithm will then adjust and back down on your insulin, right? So this development is amazing in part because there's trial data suggesting that it improves glycemic control, but it also reduces the burden of management. A lot of this is going on in the background so that the patients don't have to do as much for the management of type 1 diabetes. So now, if you again turn to your sort of standards of care guidelines, what you'll find is that there's two major statements around the use of technologies if you're a patient with diabetes. The first is around CGMs. So the first thing that the ADA recommends is that you should use real-time CGM, A-level recommendation, right, for the management of young people or adults if you're using insulin, right? A-level recommendation, it's sort of based on the strongest data possible. And again, age isn't a consideration. Young people, older adults, it doesn't matter. As long as you're a patient on insulin, which is all individuals with type 1 diabetes, you should be using these devices. There's a second recommendation, which I think is also really interesting, which is around these AID systems or the automated insulin delivery systems. So it says that the AID systems should be the preferred insulin delivery method to improve glycemic outcomes in, again, young people and adults with type 1. And again, A-level recommendation, right? So it doesn't matter what your age is, as long as you have type 1 and you're using, as long as you have type 1 and you need insulin, it says that you should use these AID systems to sort of manage your sugars, right? So given this context, right, given the importance of glycemic control and given the very strong recommendations around ADA, ADA has and different guidelines have around the use of these technologies, we had three primary questions in this project. The first is, how has glycemic control changed over time in both in both adults and in youth with type 1? The second is, how has the use of these new technologies changed over time? And then the third is, how has disparities in glycemic control and technologies use changed over time? Right? Are we seeing equal improvements over time across different populations? And so to do this, we turned to a large EHR database called the Optum's Lab Data Warehouse. And I think this is a phenomenal resource, right? So this is a large EHR warehouse that has information on labs, prescriptions, medical encounters, anything that is collected in the course of routine care and that is captured in the EHR system, we had access to. And so this database has information on over 200 million individuals over a 15-year period. And so we took all this data, and the first thing we did was we filtered down to individuals with type 1 diabetes, and we did that using a validated algorithm. And then we required individuals have data on HbA1c because we were interested in glycemic control. And our final analytic sample was just a tad bit under 190,000 individuals, right? We had 187,000 adults and young people combined with type 1 diabetes. And then we had two sets of primary outcomes. The first was just glycemic control, right? And again, we defined this in accordance to the DCCT and to standard of care guidelines of an A1C less than 7. And then the second was just the use of these technologies that are recommended for all patients, right? CGM and insulin pump. So let me show some of the descriptives of these patients, right? So in the young people, so these are all the patients under 18 in the EHR system that we are looking at. So we included a little bit more than 25,000 individuals. The mean age for the young patients were 12. And then for adults, the mean age was 45. The racial ethnic breakdown, it was about 3/4 non-Hispanic white. And then in terms of the insurance breakdown, a little bit more than 60% had commercial insurance. So this was our first set of findings, right? It's related to our first question around glycemic control. And what we found was that one of the main finding here was that glycemic control appears to be improving in young people with type 1 diabetes. So these are the results for everybody under the age of 18. And so I'll bring your attention to the left panel because these are the results just overall. And so what we found was that there was really two trends in the over the course of the study period, right? The first trend was from 2009 to 2017, almost the first decade of the study period. And what we found here was that there really wasn't change, right? It was really a period of stagnation where youth hovered between 7 and 9% glycemic control. We couldn't break that 10% mark, and things didn't really appear to be changing much over time. However, there seemed to be this important turning point after 2007. And then things began ticking up in the right direction, right? We seem to have turned a corner in terms of glycemic control in young people. And now we're almost 19, almost 20% of these patients are now reaching the recommended target. And I think this is amazing, right? This is an amazing moment in sort of the 15-year history of type 1 diabetes, because it now means that the population as a whole is now having lower risk for all these adverse outcomes that I talked about. However, and I think there are sort of two important caveats that I wanted to sort of highlight from our results. The first is that if almost 20% of the population is reaching recommended glycemic control targets, it means that approximately 80% are not, right? So while we've made important gains in terms of glycemic control for young people, there's still major room for improvement. The second thing that I think that is sort of worth tempering our excitement over is that the fact that as things improved, things also got more unequal. And so if you look in the middle panel, what we did was we broke glycemic control trends out by race ethnicity. And what we found again was that prior to 2017, things were relatively flat, right? There wasn't one group that was doing much better than the other. It's just youth in general were not achieving glycemic control over 10%. But after 2017, things began improving. But they began improving faster for certain populations. In this case, non-Hispanic white youth were achieving glycemic control at higher rates than their Black counterparts and their Hispanic counterparts. We also saw similar trends when we broke things down by insurance status, right? So again, no real difference prior to 2017, but after this period, both groups began improving, but the rate of improvement was faster for those who were using commercial insurance, right? And so now we see differences across health insurance status, which we're using as a proxy for SES. We're starting to see those differences emerge in young people. So these are the results for adults. And you can see actually the patterns tend to be quite similar for adults, right? Again, for the first three periods in our study between 2009 and 2017, we didn't see much change, right? It hovered around 20-21%. Things kind of just stayed flat, right? Not a lot of change in terms of the population. But after 2017, again, things began to pick up and improve. And now we're at 28%. Almost 30% of the adult population with type 1 diabetes is now reaching the recommended A1C target of less than 7%. Again, really encouraging signs that we as a community and as a population, we're doing better, right? And we're able to reduce their underlying risk for major outcomes. So really exciting. But the same two caveats apply. The first is that if 28, almost 30% of the population is reaching the target, it means that 70% is not, right? So again, major room for growth and improvement in terms of glycemic control in the population. The second thing is that as things, again, were improving, things got more unequal. And you can see it in the adult case as well, where things, there was differences in the population, and these began to widen over time. And we can see that when we break it down by race ethnicity. So in non-Hispanic white adults, about 30% are now achieving recommended targets compared to about 20% in those who are non-Hispanic Black and Hispanic patients. And again, across insurance status, where we have commercially insured individuals increasing at a faster rate relative to those who are on Medicaid. So I think the sort of story that I sort of see from the glycemic control side is that we're making major strides. We're really improving, but that this has come at a cost of equity, and there are still, the other thing is that there are still major areas where we can improve. So this result relates to the second question, which is how has technology use changed over time in individuals with type 1? And I like this figure a lot because you can literally see where the tech revolution began. It began right here, right? So prior to the 2017 period, this is results in young people. And the purple dot is relating to individuals using CGM. You can see prior to the 2017 period, relatively few young people were using CGMs, right? They weren't particularly accurate at this point. They weren't the most comfortable, and insurances weren't covering them very robustly before this period. After this period, when the technologies began improving and when coverage began becoming much more expansive, you can see the use of these technologies really took off. And so now in the most recent study period, a little bit more than 80% of young people with type 1 are using a CGM. So these teal dots show the percentage that are using insulin pumps, and this has been consistently growing over time. So now about half of young people are using an insulin pump. And then a little bit more than half, about 47%, are using both the CGM and insulin pump. And that's what we're calling that sort of the AID sort of approach to management, right? These individuals are using the latest and greatest, where they're pairing the CGM with the insulin pump and letting that run in the background and do a lot of the management for them. Now, in the adult case, we see a similar trend, albeit at much lower levels, right? So again, for adults, you see that the sort of use of CGMs, which are indicated in the purple, those really didn't change much, but during the first the first 3 study periods, right? Again, uptake was very, very low prior to 2017. And then after this period, things really took off. And now a little bit less than 60%, 57% of individuals who are adults with type 1 are now using CGM. I think one thing to note with CGMs, but also with all the other different device types, is just the difference between youth and adults. There are actually pretty large differences across age, right? So that it's about a 20 percentage point difference, right? So about 80% of young people, for example, are using CGM, and about 60% of individuals who are adults are using CGM. And again, I raised this because at the outset of the talk, I mentioned that individuals over 45 are now making up almost half of this population. And so I think an important priority area moving forward is thinking about how to improve CGM and insulin and just sort of technology uptake in adult populations. You can also see with insulin pumps, this sort of increased at a linear rate, so that now about 29% of those who are adults with type 1 are using the devices, and about 22% are using both the latest and greatest, right, when they're pairing both devices together, right? So while standards of care say that everybody, regardless of age, should be using this, we're quite a ways from getting 100%, right? We're at about 22% for adults. So this last set of results relates to disparities or differences across populations in terms of the use of these technologies. And I will say that these initial set of results were actually quite surprising to me. And the reason I say this is that we've actually seen some reductions in the disparities of the use of these technologies. And I was going to walk us through some of those results. So again, prior to 2017, tech use was quite low. During the next study period, 2018 to 2020, we saw the use of CGM, and this is in young people. We saw the use of CGMs really take off. But you can really see the group that was sort of the earliest adopters of this tended to be non-Hispanic white youth, right? And so they were at about 60% compared to about 40% for those who were Black and Hispanic, right? There was about a 20 percentage point difference in young people across race and ethnicity, right? And this has been noted in prior studies as well, right? This has been a persistent challenge and a persistent concern in the field of type 1 diabetes. However, and this is a pleasant however, when you look at the most recent study period, this is 21 to 23, those differences have actually declined rapidly. And the reason I was so surprised by this is because oftentimes when there are medical innovations, it takes a long, long time, if ever, for disparities to really narrow in a meaningful way. But what we saw in the most recent study period was that about 83% of non-Hispanic white youth were using CGM, and then 77% for Black, and then 78% for Hispanic, right? We went from a 20 percentage point difference to a 5 percentage point difference in the course of 3 years, right? And that level of sort of closing of differences in such a short period of time, I thought was really, I was sort of taken aback by how quickly disparities opened, but also how quickly they closed as well in terms of the use of CGMs. We see a similar pattern when we're looking at differences across insurance status, right? In the 18 to 20 period, we had about a 20 percentage point difference for those who were on commercial insurance relative to Medicaid. And again, over the course of it's a 3-year period, these differences substantially narrowed. So I was very, very encouraged by just the rapid uptake of CGM in populations where historically and even in some of the prior studies, the use has been lower, right? But it seems like we're doing a good job of broadening access to these devices for all sorts of populations. Not so much the case with insulin pumps, though. So when you look at the results for insulin pumps, there were disparities between race across race ethnicity, for example, and those disparities have really persisted over time, right? When we're looking across race and ethnicity, and then when we look across insurance status, those differences actually may be increasing in youth, and so this is quite important, I think, because now insulin pumps are not standalone devices anymore. They're integral components to that AID system, that integrated system. And so now I think thinking about ways to close this difference is going to be important. So I think it turns out the CGM story is more actually the exception than the rule, and that some of these differences are still persisting and maybe still growing in some cases. When we're talking about adults, we actually haven't seen as much progress as well, right? So when we see differences across races and ethnicity by adults, and so those differences really haven't narrowed as much. There's some actually between whites and Hispanic adults, but for whites and Black adults, we see differences that have persisted. And then across the insurance status, we see differences really haven't closed as rapidly as we see in youth. And then the same thing for insulin pumps. We see that these differences were present at least by 2017, and these really have persisted over time. And then the same for if we look across insurance status. So it turns out, I think the very promising trends that we saw for young people across different social categories ended up being one of the exceptions rather than a sort of general trend of improving access to everybody. So let me give a few concluding thoughts on some of our findings here around glycemic control and tech use. I think the first finding, and I think this one is the one I really do want to highlight, is that glycemic control is improving in young people and adults alike. I think this is so encouraging that after about a decade of no change, we're starting to see things improve at the population level, right? And this is really, really difficult to achieve, but we're starting to see it, and it's been improving over at least the last 2 study periods. So it's been a consistent improvement. We seem to be doing something right in terms of type 1 diabetes management at a population level. And I think it's something worth sort of giving ourselves a round of applause for and worth sort of celebrating. I think the rising use of technologies has been a major contributor to this. We know from RCTs that CGMs and AID systems result in better glycemic control. We see the rapid uptake of these devices, particularly CGMs, right after 2017, right? The sort of turning point for glycemic control was also the same turning point when technology use really took off. I think I don't think that that's a coincidence. I think CGMs played a major role in why we're starting to see glycemic control improve at the population level. I think we should also temper our excitement, though, right? Because 80% of young people with type 1 are still not reaching recommended glycemic control targets. And for adults, it's around 70%, right? So major room for growth, despite things trending in the right direction. We're still not quite there yet. And I think differences across different social categories like race, ethnicity, and socioeconomic status, those differences in glycemic control also seem to be increasing over time, right? So I think while things are improving overall, we still have to be mindful that not all groups seem to be benefiting equally in some of the sort of advancements in terms of the management of type 1. So where do we go from here, right? There's no right answer to this, but I'd like to highlight at least 4 things that I think, 4 priority areas that I think are important to focus on. I think the first is that we have to ensure universal insulin access. This to me seems like a no-brainer, so I won't sort of belabor this point, but this is a medication that is essential for individuals with type 1, right? And it still is, affordability is still a major challenge in the US. So we recently conducted an analysis looking at this issue. It turns out the CDC actually has collected data on insulin rationing, and this is the first nationally representative study on insulin rationing based on CDC data. And what we found was that in individuals under the age of 65, which was a population we were interested in because they don't have access to Medicare, right? We found that about 25% of adults with type 1 reported rationing insulin during the year, right? And that meant either not filling their prescriptions on time or using less medication than they needed to. And the reason for this was because they were trying to save money, right? So insulin affordability is still a persistent challenge in the US and something that we still have to find a solution to, right? This to me seems like a no-brainer, but we still are experiencing challenges with this. The second is that we have to expand access to technologies, right? We look at the standard of care, we look at some of these major RCTs, these technologies improve outcomes, and they should be standard of care, but we're not quite there yet, right? And use in particular remains lowest in certain populations, including racial ethnic minorities and those from lower socioeconomic backgrounds. And so we sort of have to focus efforts on improving access to these populations. I think the other area is in adult populations, right? I actually think we're doing a pretty good job with young people, right? At least with the CGMs. You saw that we're hitting more than 80%. I think we will get to a point where it will be relatively rare that we don't find a young person with type 1 using at least CGM, right? Adults aren't quite, the rates of use in adults aren't quite as high, right? And I didn't show the results broken down by different age categories, but as you get older and older, you're less likely to use technologies, right? So middle-aged and older adults are the least likely to use these new technologies. And there's trial data suggesting that even in older adults, there's a lot of benefit in using CGM. And so I think finding ways to get these sort of emerging tools into their hands is going to be important as well. The third point is around patient education, right? Patient and provider education, right? These tools are incredibly powerful, but we have to know how to, use them in optimal ways. And for CGMs, these things are collecting thousands and thousands of data points. And by the end of, wearing it for 2 weeks, you're just overwhelmed with the amount of data that you have, right? So helping patients and helping providers understand how to maximize the value of all that data and to use that to translate into better outcomes is going to be important, right? Because there's going to be a lot of new users. They're just going to be sort of overwhelmed or possibly overwhelmed with all that data. And I think it'll be important to sort of, again, help people sort of maximize the value of these technologies, right? It's not enough just to give somebody a CGM and just sort of let them go, right? You need to sort of give them ongoing support. And then the last thing I think that is going to be vital, and this of course could be its own talk, right? Where we know that the medical factors, medical factors play an important role for glycemic control, but that's only part of the story, right? There's going to be fundamental social and environmental factors that also shape glycemic outcomes, and that we need to sort of address these in tandem, right? The medical factors and the broader social determinants of health are going to be things that we need to consider to improve glycemic control outcomes in the population moving forward. Okay, so now I want to shift gears a little bit and talk about obesity in type 1, right? And I think one thing to note about obesity is that I think it's an underappreciated issue in the population with type 1. And so there was a really nice summary review piece written in Lancet DE a few years ago. And you'll see that the opening sentence in this review, I think, is revealing, right? And what they say is that although type 1 diabetes has traditionally been considered a disease of lean people, right? And I think that perception is right. I think just like we typically think that type 1 is a young person's disease, we've also had this notion that it's a skinny person or a thin person or a lean person's disease, right? But there's emerging evidence suggesting that this simply isn't true, right? That the really skinny kid that you see in like various case reports, that's not really the sort of standard case of individuals with type 1 in contemporary US society today. I think one of the limitations of existing research, though, is that most of the research has been in single clinics or single health systems. And so you're curious around the degree to which those findings are generalizable to the broader population, right? And we did note that there's been a lack of representative data trying to get at this question. Fortunately for us, again, that CDC data set that we initially analyzed to estimate prevalence, they also collected information on BMI. I think the main caveat here is that BMI was self-reported. So you sort of take it with a grain of salt, right? Because this is self-reported BMI. But I think it's still useful to get a general sense of what rates of obesity and rates of overweight might look like in the population, right? And so what we found was that 62% of adults with type 1 diabetes may have overweight or obesity, right? This is not a lean person's disease, right? I don't think the data support that notion anymore. And I think that sort of belief in that stereotype has sort of prevented us from thinking about strategies to think about weight management in this population, right? If you don't consider something a problem, then you're not going to try to develop, workable solutions for it. The other really interesting thing is that when we compared the rates of obesity in those with type 1 to those without diabetes, we found that the rates of obesity are actually quite similar, right? And rates of overweight are quite similar as well. So it turns out the weight profile in individuals with type 1 is very, very similar to the weight profile in the general population. And so we often say that there's a sort of obesity crisis or obesity epidemic in the US more generally. And I think if that's the case for the general population, I think you can make the same statement for those with type 1 diabetes, right? Rather than it being a disease of lean people, I think there's actually an obesity epidemic growing in this population. And it's something that is not widely acknowledged and something that we need to think more about because we need to develop strategies for addressing weight management. The other really fascinating thing that the CDC collected data on was lifestyle management, right? So in addition to asking about BMI, there were sets of questions around whether or not your doctor is telling you that you should increase your physical activity and whether or not you should think about reducing your caloric intake, right? The data set also included really interesting questions around whether or not participants were actually engaging in these activities, right? Are you currently increasing your physical activity level, and are you currently reducing the amount of calories you're intaking? So for these analyses, we limited our sample to individuals with a BMI over 25, right? So individuals who were overweight or obese. And the rationale for that was, lifestyle management is first line for managing overweight and obesity. And so we wanted to see among those who had overweight or obesity, how many of them are actually receiving this sort of lifestyle counseling and how many of them are engaging in this sort of lifestyle change. So it turns out the answer is about 50%. So in individuals with type 1, about 50, a little bit more than 50, so 54% said their doctor had told them they should begin increasing their physical activity. And then about half of them said, yes, you should be dialing back your calories. And then when you look at the percentage that are actually engaging in increased physical activity and then reducing their caloric intake, again, about half, 51% said, yes, I'm currently increasing my level of physical activity. And about 56% said, yes, I'm dialing back calories currently. Right. So lifestyle management remains, I think, an area that we just have to think about more carefully and there's lots of opportunity for improvements. Right. Only about half of individuals are actually engaging in lifestyle management that should be first line for everybody. So one of the questions is why, right? Why is it only about 50%? Why does lifestyle management remain suboptimal in individuals with type 1 diabetes? And I think one of the things, if you sort of look through the literature, one of the most sort of common recurrent explanations relates to the use of insulin, right? When you mix insulin with very rigorous physical activity, one of the things you're at really high risk for is hypoglycemia, right? Or your sugar is getting very, very low, very, very fast. And so there is that risk that if you engage in very rigorous activity, you could, potentially pass out or even worse, right? And so in qualitative studies where they interview patients with type 1 and they ask them, hey, why aren't you performing more physical activity? One of the most common things that comes up is, I'd like to, but I don't want to do it and compromise my safety, right? And so one of the big issues I think moving forward that we're going to have to think more about is how can we support individuals who are trying to increase their engagement in lifestyle management? How can we do this more safely? Right? Because this has been a persistent challenge for a long time for individuals with type 1. And it's a somewhat unique challenge to them, right? So individuals obviously who aren't with diabetes, they're not using insulin, right? So they don't have that sort of safety challenge. And the vast majority of individuals with type 2 are also not using insulin. So they don't have that challenge as well, right? So this is a somewhat unique safety challenge for folks with type 1. And I think something that is going to be important to think about and address as rates of obesity become continue growing and becomes more common. So the last paper I'd like to talk about is a paper that we recently published, and this was led by a postdoc here at Hopkins, Yunwen, and she did a wonderful job on this paper, where we looked at trends in obesity, but also the use of these new medications, the GLP-1 RAs, which are known to cause large amounts of weight loss. So a little bit of context on GLP-1s and the use of GLP-1s in type 1, right? The first thing is that obesity may be this growing challenge in type 1, as I've shown some data for. Interestingly, GLP-1 RAs are currently actually not approved for patients with type 1 diabetes. And I think a large part of that is due to the fact that there were early liraglutide trials where they tested the effects of sort of these early generation type GLP-1s in people with type 1. And what they found was that it was beneficial, right? Individuals lost weight. They actually improved, A1C was reduced, and their insulin requirement actually went down. But at the same time, they actually found increased rates of hypoglycemia and DKA, right? And DKA is diabetic ketoacidosis, where your sugars get very, very high. And so on balance, right, the sort of risk ratio, the risk sort of benefit ratio didn't quite shake out. And because of that, these early trials suggested it may not be sort of beneficial, sort of on balance for patients with type 1 to use these medications. And interestingly enough, that sort of sense that it may be an unsafe drug, potentially have some safety issues, persists, right? So if you have some of the sort of current generation of medications, right, the semaglutides, right? So if you have Wegovy or if you have Ozempic and you open up the FDA warning label or the drug label, there's actually an explicit note about hypoglycemia in there, right? And it says that concomitant use with an insulin, right? So if you mix a GLP-1 with insulin, this may increase your risk for hypoglycemia, including severe hypoglycemia. Reducing the dose of insulin is going to be necessary. You have to inform the patient around the risk of hypoglycemia and educate them on the signs and symptoms, right? So the use of this medication may not actually be that safe in individuals with type 1 diabetes, right? And so we were really interested in understanding, well, there may be safety concerns around the use of this medication. How many people are still using them, right? So that's what we evaluated in this paper. So again, we turned to the Optum data set, which is a national EHR database, same analytic sample, around 200,000 individuals with type 1 in this analysis. And so we had two major outcomes. The first was just rates of obesity, and then the second was the use of GLP-1 RAs. So here we looked at, again, rates of obesity as opposed to that just single time point that I showed you guys in some of the earlier slides. And here we're looking at young people as well as adults. I think the third thing that is worth noting is that this is actually measured BMI versus the other one, which was self-reported. So this actually has more reliable sort of measurements of rates of overweight and obesity. But what we found was that in young people, the percentage with obesity has been increasing quite dramatically. So we've gone from about 18% to 26%. So a little bit more than 1 in 4 young people with type 1 now have a BMI over, actually, I guess for children, it's a Z-score, but they have rates, they have obesity, right? In adults, we've gone from 30% having obesity to about 38%. Again, very, very on par with the adult population. I think NHANES puts the most recent prevalence estimate at around 40%, right? So again, those with folks with type 1 and the general population it seems like they have very consistent weight profiles. The other really interesting thing to note is that rates of overweight are also still remain high, right? So if you add up obesity and overweight, it's 38 plus 32. So in the adult population, about 70% have either overweight and obesity, right? So again, this is not a population that is a quote unquote, this is not a disease of quote unquote lean people anymore, right? Overweight and obesity, just like it for the general population, this is a very common risk factor now in folks with type 1. So what about the use of the GLP-1 RAs, right? So on the left-hand side, we show the use of these medications in youth, and then on the right-hand side for adults. So what we found for, regardless of age, what we found was that the higher the BMI category, the more likely it is that someone's going to be using a GLP-1 RA. I guess that's not so surprising, but it is just worth noting. And so in young people, rates were relatively low in the most recent study period, but we did find that if you're a young person with type 1 and you had class 2 or class 3 obesity, about 21% of these patients were currently using a GLP-1 RA. The second thing is on the adult side, you see just sort of this very strong dose response relationship. And so in individuals, in adults with type 1 who were class 3, about a third of them are currently using GLP-1 RAs. I think this is significant given some of the context, right? There are some safety concerns around the use of these medications in individuals that are using insulin, right? There are explicit warnings from FDA labeling around, hypoglycemia, particularly severe hypoglycemia. And despite this, we're seeing just sort of, high use rates in this population, just like in the general population, right? And so I think this is, again, an important area for future research, right? Are these medications safe, and what are strategies we can implement to mitigate potential risks, right? Because there are warning labels, but it doesn't seem like that it may sort of influence the decision making, but it seems like there's also a large portion that says, look, I'm going to use these medications, and I think I can sort of balance the risk. But I think we need explicit research and explicit trials understanding efficacy and safety of these drugs more sort of systematically in patients with type 1. Okay, so let me give a quick summary of some of the obesity findings. I think the first is that obesity has reached epidemic levels in folks with type 1 diabetes, both youth and adults, right? Not a disease of lean people anymore. This is a population with rates that are very, very comparable to the general population. I think one of the unique things about this population is that there are major safety concerns, right? Just going for a rigorous run around the block is not something they can do without sufficient planning. And the same thing for the GLP-1 RAs, right? You may, but there may be challenges in just starting this medication, right? And so I think we need much more research around how we can engage in lifestyle, both effectively, but also safely for this population. And then on the pharmacoepi side, or the pharmacotherapy side, I think we need much more research around how we can implement some of the new drug innovations, particularly the GLP-1s, in a safe and effective manner, or we even sort of raising questions around whether or not they're safe and should be used in this population, I think needs to be very carefully explored. Okay, so with the last couple minutes that I have in this talk, I want to talk a little bit about future research and where I think it might be useful to go in terms of understanding population health and type 1 diabetes. And so I'll begin this section not talking about type 1, but actually talking about type 2. And so it turns out in the US, we have systematically tracked type 2 diabetes very, very rigorously for decades. Right, we have national studies like the NHANES and NHIS. We have registry data. We have vital statistics. We have claims data. We have hospitalization records. And we're able to take all this information, kind of layer it on top of each other, synthesize it in very kind of meaningful ways. And it's provided valuable insight on ongoing and emerging challenges in the population, right? It turned out we know how many people have type 2 diabetes, how many people are at risk for type 2 diabetes, how well it's being treated, how well it's being managed, and what sort of rates of complications look like, and how life expectancy looks like. And all this information has shaped prevention, it's shaped screening, it's shaped sort of strategies for treatment, and it has shaped efforts addressed at disparities. The other thing that the CDC does is that it takes all this information and it synthesizes it into, I would argue, probably one of, if not the most important public health resource related to diabetes in the US, and that is the National Diabetes Statistics Report. Right? This is something that they update on an ongoing basis and just provides so much information for policymakers and for people engaged in public health planning. And it has a profound impact on sort of public awareness around how many people have the disease and how we can manage and prevent this condition of type 2 diabetes. I think what we would like to do at Hopkins is do something similar for type 1 diabetes, right? This level of infrastructure and this level of surveillance doesn't exist for type 1 in the US. And I think we're now poised to do that. I think we have the requisite pieces, and now it's just it's about sort of assembling things in a meaningful and strategic way, so that we can provide so that we can get similar insights, right? So we can pull on national survey data like the NHIS, which the CDC runs. We can draw on large EHR database like Optum, like we've done in some of our existing studies. And we haven't done this as much, but I think there's lots of resources from major NIDD case studies like the Teddy study, where if it makes sense, we can pull that in as well, right? And so in the same way that the CDC layers all this different sort of surveillance information for type 2 diabetes, I think we can do the same thing for type 1 diabetes. And if we're able to do that, I think one of the major deliverables that we would like to produce is a national type 1 diabetes statistics report. I think this could be a major, an incredibly valuable resource for the field in terms of public health planning, in terms of prevention, in terms of understanding management, and in terms of addressing disparities, right? Developing a systematic report that gets continuously updated, I think can really push us a long way in terms of understanding population, improving population health as well. Okay, so that's the end of my talk. So I just want to give a few shout outs to everybody involved in this work. My main collaborators on this there were 4 main collaborators. The first was Liz. So Liz Selvin is my main mentor at Hopkins, and she was the first person to sort of like suggest and push me on this whole idea of type 1 using EHR. I was sort of skeptical about doing surveillance using EHR data, but now I'm not. I'm a total believer. So Liz, you were right about that. My second collaborator was Jung Im. And so Jung Im is one of the leading experts in the world around EHR data. And so I've learned so much in terms of just sort of using these data effectively under her guidance. The third person I'd like to give a huge shout out to is Yunwen. She's a postdoc who's currently a postdoc, but she'll be transitioning to faculty. And she's just our data guru. She knows everything, the ins and outs of Optum and all these various EHR database. And she's produced all the sort of code base for doing our analyses. So it's just been such a pleasure to work with all you guys. And then the last person I want to sort of highlight is Justin. He's our colleague in endocrinology at Hopkins, and he brings all these sort of wonderful insights, but especially from the clinical side. And it's really great because I'm not a clinician. So he'll be like, oh, that's not what we do in practice. And so I'll have to rewrite my whole paper because Justin didn't like it. So I want to also give a huge shout out to all my colleagues, of course, friends and family, everyone here at Welch for all the support, and then everybody at Bloomberg for all their support as well. And so I want to thank everybody for listening. Hopefully I didn't go over time, but I'm happy to take any questions that people have. Thank you.
Thank you very much, Dr. Fang. We have time for just a couple of questions. There is a laundry list of questions that have come in, and there's no way that we'll get to them all, but we will present you with a list of the questions and encourage you to prepare very brief answers, and then we can post that on our website along with the slides and a recording of the presentation. So one of the questions, what are the reasons that children or adults are not using the technology? Is it knowledge? Is it access? Is it cost or insurance? Why aren't kids and adults using the technology that seems to be so useful?
Yeah, that's a great question. I think the barriers to use, at least for adults, I think those have been more kind of systematically laid out. And I will point people who are interested to this really fantastic review in diabetes care around the growing use and some of the existing barriers in older adults. So I'll focus on the older adults for this portion of the question, right? So this group sort of laid out a variety of factors that they think may be driving sort of under uptake or under use in older populations. And I think I'll highlight a few in kind of the patient level and then some of the provider level. I think one really interesting thing is the sort of idea of reluctance to change, right? If you're a patient and you've managed your type 1 diabetes in a certain way for a long time, you may not want to change. You're like, I'm so comfortable with the syringe and the needle. Like, why do I need an insulin pump or why do I need a CGM, right? And so in some of my conversations with clinical colleagues, they'll say, yeah, there's a lot of patients who are reluctant. And then you say, just try it. And then they try it and they really love it, right? And so breaking that initial reluctance and that initial inertia, I think is a challenge. But oftentimes, once you sort of break that sort of hesitation, it turns out a lot of patients really like it. So that's, I think, one really important factor. You mentioned tech literacy. I think that is something that may be a challenge. Also, the sort of confidence with tech, right? I think, patients are probably able to do it, but they're sort of afraid. Like if I adopt this and this sort of tool, but I'm not quite sort of tech savvy enough to do it, like maybe I shouldn't even try. And so again, I think that speaks to the need for support, right? So ongoing support and of patients, helping them sort of with the initial sort of uptake of these devices. Because once they learn, I think at least with the CGMs, it's not the devices themselves, at least with CGM, they're quite passive, right? You just sort of put them on, and it's really sort of non-invasive and really intuitive to use. There are challenges with aging, right? Cognitive and functional issues. And then oftentimes, if you're an older patient, it may not be that actual patient who's managing the disease, but it may be sort of a caretaker, right? And so you may not have a caretaker, or your caretaker may not be comfortable with using the devices. There's also a list of provider level factors, but I won't sort of go through those systematically just for the sake of time. But again, anybody who's interested, I think this is a really fantastic review in diabetes care that I will refer people to.
Thank you. What protective factors, aside from potentially reducing obesity rates, would GLP-1 agonists provide for type 1 diabetics?
Yeah, so I've talked about them in the context of obesity, which is sort of a narrow benefit, right? It turns out these drugs, these drugs have all sorts of benefits. I suspect some folks here have probably read about them, right? I think in particular, what I'd like to highlight is that these drugs not only help individuals lose weight, but they also have cardiorenal protective benefits. That is, they reduce your risk of cardiovascular disease and they reduce your risk of kidney disease. Right? And these are two major issues in the population with type 1 diabetes. I think that's another reason why folks with type 1 or advocates and clinicians are really excited about these drugs for type 1 patients, right? It's not just about the weight. I think the weight is an important emerging risk factor, but it's sort of these underlying major endpoints. Those are actually improved and reduced dramatically with the use of a GLP-1. And so I think I think that it's a really important benefit of these drugs that needs to be evaluated in the population.
Dr. Fang, I want to thank you for an outstanding presentation. I want to thank our attendees for their many questions. I apologize that we're not able to get to them all. We will present the questions to Dr. Fang and encourage him to prepare brief answers, and we will post that information on our website once we have it. As I mentioned earlier, we will be posting the slides and a recording of today's presentation on our website in the next few weeks. I want to thank everybody for joining today's lecture.